IASLC is embracing a liquid first program. What will it take to have the confidence with liquid biopsy? Dr. Hart?
Well, I think multiple studies have shown that patients do very well when treated based on a positive result from a liquid biopsy, and their outcomes seem to be very similar to if you find the same alteration with a tissue biopsy. So that's why international associations like the IASLC have endorsed this. And many of the, especially in the lung cancer field, many lung cancer specialists and experts will, including myself, I include myself in that, we will get a liquid biopsy when we first see the patient. There's very little reason from my standpoint not to get it when you see a patient that has a diagnosis, and you sort of take whichever result gives you a positive direction first, either liquid or tissue, because as I mentioned just previously, often there's not enough tissue. Either it's from, the first diagnosis could be from a malignant effusion where there's just cells from a thoracentesis. Sometimes there's a small biopsy, a needle biopsy, or a bronchoscopic biopsy where there's a small amount of tissue, and it has to be sent out to an outside lab. Many hospitals, medium or small size hospitals, don't do these things in-house. Even academic centers don't do them in-house. So the liquid first makes a lot of sense because obviously lung cancer is an aggressive malignancy, as was mentioned before. You want to try and get to the proper treatment as soon as possible. And there have been multiple studies that show that you can rely on a positive result from a liquid biopsy, and the patient will have a very similar outcome as if you found that same mutation in a tissue biopsy. So if you get both, I tend to send both out and take whichever one gives me a positive result that I can act on first.
Wow. Thank you for sharing. Dr. Reeves?
Yes, I'd agree. And I think it's important to note that, with either method, that if you get a positive result, that is to a very high likelihood a true result. There really aren't false positives to speak of unless somehow someone else's tissue gets in that specimen. The liquid is going to tell you the truth, and the tissue is. It's just that their results are going to overlap. Some things are going to be seen in liquid that may not be seen in tissue, and vice versa. So it's ideally you'd want to try to get both eventually. But if you see an actionable result on liquid or tissue with our current level of technology, you should assume that's a true finding and you can act on it.
Thank you. Dr. Walker, do you have anything to add?
Again, I completely agree with Dr. Hart and Dr. Reeves that with IASLC, their consensus statement this summer published in October really was a huge step forward. Tissue and plasma and GS molecular testing is complementary, but do the plasma first. You can get it with a simple blood draw, get it back within 7 days. As Dr. Hart indicated, tissue will take a week for the pathologist to go through what they have to do, the block to be sent out, and then it'll take 3 weeks to get the tissue results because of the large panels. And we always talk about a positive result. What's sort of unique in the lung cancer space is before you start immune therapy, you need to exclude an EGFR mutation, an ALK fusion, and a ROS1 fusion. So getting the results that don't identify those things do help guide the best treatment for